विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बात के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता आया हूँ, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया टुमारो।
Good morning, friends. Welcome to the second edition of the Elets Hospital Infrastructure Summit. I am Mrinmoy Bhattacharjee, Assistant Editor with Elets Technomedia, and I'll be your host for today's sessions. The theme of this edition is delivering fit-for-purpose healthcare facilities. And today and tomorrow, we'll be discussing a range of issues from managing aging population, design trends, future of healthcare facilities, IT applications in remote patient monitoring, and much more. At this inaugural session, I have the pleasure of welcoming Dr. K. Madan Gopal from Niti Aayog. Welcome, Dr. Madan Gopal. Dr. Madan Gopal has over 28 years of experience working on issues related to health systems reforms. He is a health professional equipped with MBBS and MD degrees. Presently, he is working with Niti Aayog, the apex policy think tank for the Government of India, as a senior consultant for health. Joining us shortly is Dr. Atul Mohan Kochar, CEO for National Accreditation Board for Hospitals and Healthcare Providers. Dr. Kochar is passionate about quality and strives towards taking quality to the last man in the line. He is a life member of IADVL and Society for Pediatric Dermatology and a fellow of American Academy of Dermatology. Joining us shortly is Professor Sharman Singh. He is Director and CEO of All India Institute of Medical Sciences, AIMS Bhopal. Dr. Singh is an able administrator and hard taskmaster and has a good administrative and constitutional knowledge. He is now internationally acclaimed medical scientist with outstanding research and academic achievements. He is one of the upper 10% peer reviewers of publications from topmost publishers like Elsevier, Lancet, and many more. Overall, he is a manuscript reviewer. I would now like to invite our managing editor, Mr. Karthik Sharma, for his welcome address. Over to you, Karthik.
Thank you. Thank you, Mrinmoy. And it's my pleasure and honor always to deliver the welcome address, and especially when stalwarts like Dr. K. Madan Gopal, Senior Consultant for Health in Niti Aayog, and eminent leaders like these participating in these events. It really adds great value to any conference or any discussion forum when such thought leaders are there with us. Welcome, Dr. K. Madan Gopal. And I also welcome the audience which has started joining us and watching us on the Avatar, which is a virtual 3D platform by Elets Technomedia. As we all know that the healthcare infrastructure, the hospital is the one of the most important aspects of any healthcare infrastructure. And here we are discussing on this second edition of Hospital Infrastructure Summit, with the theme of delivering fit for purpose healthcare facilities. It becomes very important because in COVID-19 era, we have seen huge transformation in our healthcare infrastructure, and we are still seeing huge transformation in the hospital infrastructure. You can see the building aspect, or the services aspects, or various different aspects are transforming now post COVID-19, or we can say during COVID-19 era. And at this time, this discussion becomes really, really important. So, without uh, 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 using much of the time, I would like to uh, welcome once again everybody, and thank everybody and those who will be joining us in next 2 days, today and tomorrow. I would like to welcome all, and here I conclude my welcome address, and over to you, Mrinmoy.
Thank you, Karthik, for your welcome address. I would now like to invite Dr. K. Madan Gopal for his opening remarks. Mr. Dr.
Okay,
Gopal, please.
thank you, Minoy, and thank you, Karthik, for the welcome address, and thank you, Alex, for giving this opportunity to speak on this occasion. It's the right occasion. That means we were all grappling with the issues of health infrastructure, the HR, and the other thing, and as the things are unfolding, now we have to start rethinking that this is a time to invest in the healthcare infrastructure and see that how we prepare for the coming days. As rightly mentioned, healthcare is the basic right and right of every citizen of any country. Hospitals, nursing homes, clinics, medical camps form the platform of this healthcare delivery. Nevertheless, it is the doctor, nurses, and the other medical staff. Unless they are there, these health infrastructures, they are just infrastructure. Unfortunately, in the country with a huge and growing population, little we have little number of hospitals. If you look at the density of the hospital per bed, hospital bed per population, it is around 870, one bed for 870 people. Whereas For the world average is 30 hospitals per 10,000 population. That means you see 30 beds for 10,000 population, whereas we are having one hospital for 879 beds. You see where we stand. Currently, I'm just citing the figures of 2017, this health information, health portal from the national health portal. We used to have at that time around 14,000 hospitals. And if you look at the recent health portal, this national health portal figures, the number has not substantially increased. You see the problems which because of not investing into this, you might have appreciated during COVID time. The number of beds have increased in urban areas, and the country level remains around 1.31 per 1,000 population. This is the number of beds in the urban areas. With the launch of PMJ and 500 million beneficiaries, there would be a requirement of around 0.64 million beds, additional beds over the next 10 years. So from where we would be having these beds? And if you take an hospitalization rate of 5.5% with an average occupancy of 72 and average length of stay of 8 days, where we stand? These are the questions which we need to ask. It's not that we are not currently working on that. These are the questions we have to answer. If all the 500 million beneficiaries at the rate of 5% utilization, so where are the beds to provide services to these people? Secondly, we have seen 3 times more growth than the 2017 figures. But we need to focus on tier 2 and tier 3 cities. Major expansion has happened in tier 1 cities. We have to focus on investment of private players, both profit and not for profit. Recently, we have done a study of not for profit hospitals. That's the first of its kind in the country. And we are trying to see that how we leverage this not for profit segment for increasing the bed capacity in the country. We are focusing not on increasing the number of beds. We are trying to focus that each and every bed which is used for clinical purpose, that needs to be put into use for medical education purpose also. Side by side, we are envisaging that whatever beds are created, that should be put use for training purpose as well. So with this, we have been working to see that how to cater this required demand. There has been an estimate that we will require around 300 trillion Indian rupees over the next 10 years for overcoming these shortages. From how this investment will come, we don't know. We have to explore possibilities of this. Apart from that, if you look at the utilization pattern, the people who are aware, who can afford, so they usually throng to the hospitals and utilize these services. Next thing is, we have been always saying that 70% of the care is happening. It's not the case like that. 70% of the health expenditures happens in the private sector. You see, that means there is a need for secondary and tertiary healthcare, and maximum expenditure happens on these segments only, including the diagnostics, the medicines, and the investigations. You have to see that how due to this catastrophe we can improve. If you look at the objectives, we are trying to address these things keeping in mind the following objectives: how to improve the supply of the healthcare, as well as how to increase the demand for quality of healthcare. The quality of healthcare, I think your knowledge partners NABH would be telling it, but nevertheless, lot of effort is required in the quality of the care provided by this institution. Not to talk about the accreditation process, but beyond accreditation, we have to see that what kind of quality services are being provided, so that the outcome of the patients and the others can be monitored. It may not be necessary if the hospital is accredited, but whether it is providing quality services or not, we have to move in that direction. That how to ensure quality services through the accredited institutions. From the private sector, we are having let's say NABH accreditation, full accreditation, the entry level accreditation, and the other JCI accreditations are there. For the public sector also, for improving the quality standards, initially we tried the ISO certification, then we have moved towards this NCOS accreditation. So for the public sector hospitals also, for the private sector hospitals also, we are having this accreditation mechanism. Having said this, you have to focus more on building quality services. That means what are the outcomes of having these processes, and whether the patient is benefited, whether he is receiving quality services or not. What are the outcomes in that public, this accredited hospital versus a non-accredited hospital? You have to focus on that so that a quality of care is improved. I'm just coming back to the initial figures of how we should be investing on the quality thing. One is looking at the need for infrastructure. You, the ministry has come out with the IPHS, Indian Public Health Standard Guidelines, which says that there's a lot of infrastructure gaps. If you look at the IPHS guidelines released in 2021, that's a, if you just project the requirement, then you will require at least 5 lakh crores to fulfill all that requirements. Another thing is to cater the needs of PMJ. I have already told that we require at least 6.64 million more beds in the coming 10 years. But if you look at the pattern of all the things which is happening, so we are more or less focusing on a single specialty expansion network. So that trend is there. If one cancer institute is there, they will try to have more cancer network. If a eye institute is there, they are having a more cancer network. We have studied many models, and we are trying to, we are just grappling that how to crack this issue. We are studying many models. We are having greenfield models, we are having revenue sharing model, we are having models where the government acquires the lands and gives it to the private player. All these models are having pros and cons about how to bring in the more investment. We have come up with a brownfield model, co-location kind of thing. These all models have been tried, but there are many issues with all the models. Even the viability gap funding, the Odisha government has tried it. We have to wait and see that how that investment model of Odisha comes up. There are many issues. One of the major issues which have been identified, which have been communicated to the state to address this issue, it's not that the government is not working with that. We're trying to see that how we mobilize this thing. We have identified the issues and we have communicated that issues. High level talks are going on, and we see that how we move in that direction. In the viability gap funding also, they say one of the reasons is say that the project is not viable. The return of investment in any healthcare investment is around 7 to 10 years. There also we are saying that viability gap funding mechanism is there, but hardly any viability gap funding projects in the healthcare. In 2017, healthcare has been accorded an industry status, but lending as per the industry status has not happened. Nobody has come forward and taken investments. But nevertheless, there are many. We have tried to see that how the 35 section of this income tax, which many of the private players they are requesting, how that can be leveraged to incentivize the private providers so that they can increase the bed capacities. These are some of the common issues which I would be citing is one of the major reason is the land use changes and permissions under various statutory provision for starting hospitals. The states have been informed about that, and many of the states, after that guidance notes are sent by the ministry, they have started working on that. Now you will be seeing that a single window clearance and other things are happening for improving the infrastructure investments in their particular states. The permission requirements are also there. There are many permissions. If you talk about this, it can range from 25 permissions to around 60 permissions for starting an hospital. Another important challenge which is there for starting an hospital or for any infrastructure is the HRM, recruitment as well as retention. How you will find the appropriate doctor, appropriate person, the nursing staff, the paramedical staff, how to mentor them and how to retain them. Retention is one of the major challenges. You can mentor them. After you have mentored, that kind of poaching and other things happen, and it's very difficult to retain that kind of this. Apart from that, when the government is giving some subsidies and other things, one of the issues which we have found out is the timely payments for services provided under various schemes. Apart from that, the hospitals, they are not treated at par with other establishment. The electricity charges, they are very high. We have to see that how we crack the issue of electricity at the commercial rates. Because one of the major things which any hospital faces is the electricity charges. If you are maintaining for a 100-bedded hospital, the things are very, very high. Apart from that, we have interacted with the banks also. The banks says that there is a question on bankability of the hospital projects, the return of investment, because there is a lock-in period of the capital amount, and how much time the investor will wait. You have seen examples where the investor want to come out, but he has to devise a different mechanism for coming out. As a result, he was caught, and that kind of the famous things, infamous things are happening. Apart from that, there are challenges in the PPP project in the form of cost of running versus cost of running or equipment gap, lag in liquidity, guarded operations, and cash flows. Another important thing which you have is the cost of acquisition of a patient. That is also very important, because if you are not factored the cost of for acquisition of the patient, we would be surprised that in a private practice at a rural area, the cost of acquisition can go up to 30 to 70% of the procedure cost. We have to see that how we address this thing so that we can crack this issue and see that how the investments and the requirement follows. So we have been working on this. Many models are there. We are trying to deliberate on this model and see, because one thing doesn't fit for all the things. That's not showing good. But if something has succeeded in one state, whether it can be replicated in the other states or not, we don't know. We are still grappling with the issue. It's finding out a proper solution. Many models have been mooted. The recently viability gap funding is there. We see that how awareness is created among the different players for utilizing the scheme. Then Atmanirbhar Swasth Bharat Yojana is there, which is focusing on building an infrastructure in the public sector, and as well as a network of public health laboratory, more or less a response thing. Even the 15 Finance Commission has also highlighted the need for having a health infrastructures. So what can we do? We have written, given a guidance note to the state ministry has sent a guidance note. So we are seeing that how the states take it forward, because the health is a state subject. We can only act as enablers for that. We can see that how the permissions approval, including environmental clearances, are given without delay. The single window clearances which we have seen, we have to make it really a single window clearance so that it becomes facilitated for the people. Then the requirement of medical equipment, skilled employees, we have to see that how that is standardized. The number of hospitals to be opened will be enormous. We have to see that how we standardize the requirement of medical equipment, the skilled employees. Then we have to see that how the different models can be incorporated there, and we have to explore a long-term financing option for the healthcare, because all the investors and other things, they want a short-term this and healthcare, because unless you stay there for and make the project viable, the return of investment and then the repayment of the loans is very difficult. We have to see one of the important suggestions which have been given by the investors and others, private players, during our discussion was simplification of tax regimes. This is that how we see that, so that this can be this. So this is all from my side. We see that with the efforts of all, how we can take it forward. Thank you very much. Thank you.
Thank you, Dr. K. Madan Gopal, for your opening remarks. That was a comprehensive picture. I would now like to welcome Professor Sharman Singh, Director and CEO of All India Institute of Medical Sciences, AIIMS, Bhopal. Professor Singh, I would like to request you to give your opening remarks. Professor Singh.
Thank you, Mr. Bhattacharya. I was just listening. Sorry to join late because the camera was not supporting, so we had some technical glitches. This is also part of the infrastructure, I think, and I was listening because I had opportunity to listen Dr. Madan Gopal earlier also on some other platforms. So I could hear him for a few minutes. Wonderful talk, Dr. Gopal. And I think he was the appropriate and most suited person. But from the administrative point of view, heading one institute, I can say that definitely India has a huge scope. Government of India is trying its best, but I think the last remark of Dr. Gopal, I would like to take it forward, because most of our entrepreneurs or even the established firms, they are looking for that is probably the weakness of India, that they look forward for immediate returns. Earlier also in another meeting about few months back, also before the second wave of corona, I mentioned this because probably they need to be little patient, and then only return can come. That is definitely there because they are working for the return. They are doing business, so that has to be there. But this cannot be expected overnight, and that is the reason probably our engineering sections or our those who are in the infrastructure development, uh, uh, you know, uh, entrepreneurships, or as I said, the established companies, they need to, Ratan Tata probably that is the only example they are looking forward, and they are setting up various hospitals. But other than that, probably they all look for immediate and returns. So that is probably we need to have our mind change. uh, I will give you few examples, and which because I always say that COVID, whether it is COVID or HIV/AIDS, these epidemics and pandemics, they teach us many things. They of course they are not welcome because they kill many, and they you know infect millions of the people. But definitely they go with several lessons which we need to learn. Uh, I always say that HIV also taught us many things as far as health infrastructure is concerned. The COVID has also probably exposed whole world. I say I am using the word expose, but this is conscious, decision to give the word exposed. The reason being that many of, not India, but even the developed world, Europe and America, they used to think that they have everything. As we are discussing India is discussing now, the America, they think, they thought that they already have everything. But we know now that, how we, whole world, when we say we, then whole world, we felt that how, small we are against a very tiny virus. And then coming to India, we know that we were having the this is not a hidden fact, but we know that we were not having oxygen plants, generation plants, and even if we were having oxygen generation plants, the transport systems, they were not in place, and therefore in last few months definitely we have come up with a lot of this kind of setups. But again, another some of these things I am discussing because of my own experiences. We wanted to have a urgent screening OPD, and we were not having any tender or you know quotation or any interested person. And we know that one company came forward in Madhya Pradesh, and they erected it, but in one storm it was upside down. So we can imagine that how I think how much we need to uh, develop our engineering skills. Other than army, I am not aware that any private sector they are having that they can make like 500 bedded or 200 bedded hospitals. To best of my knowledge, I'm maybe because we tried our best, we didn't find any. And one person came in Bhopal, and then we were in the process. Fortunately, by that time, this the another tent, I am saying the makeshift steel tent, that was the honorable chief minister was to inaugurate, but before that it had that thing, unfortunate thing, and then obviously we couldn't go forward. So these are the I think some of the things. And then now, other than hospital, we know that hospital settings in the rural areas, because the corona these days, we know that we have been talking, and obviously even though corona is number is less, but still we don't know that how it can come again. In rural areas, I still think that we don't have approach roads, we don't have supplies, We don't have chains of the drug supplies or the oxygen supplies. So there is no network. So I think the Niti Aayog and everybody, they have been thinking about that. And the vice chairman of the Niti Aayog was here in Madhya Pradesh that time also. I emphasize that probably that like they have made in one cluster in Delhi and probably Bombay, Pune, similar kind of clusters, not only in health, in all kind of spheres. They need to have clusters, because why I say clusters or the networks, because no one person or no one agency can do everything. So we need to have the strength shared, that some company or some person or some organization is strong in this thing, another is in this thing, and therefore we need to collaborate, we need to form networks or clusters for that matter. So we suggested that maybe Indore, Bhopal, or maybe Jabalpur or something like that. So whole country, we need to have the state-wise or even the inter-state clusters. We should identify that what is our strength and what is another's strength, and then we utilize our strength and then we work together. That probably might be very helpful. We also know that other than health sector, in teaching also we need to develop a lot of infrastructure. We know that even though the online teaching was had to be taken because of COVID, but we know in rural areas, the poor people, they couldn't, many of the children, they lost their schools because they don't have the internet, they don't have the 4G or 3G or smartphones. So this kind of things. So if we can think of the advanced education or advanced healthcare or advanced developmental issues, but before that we need to think, and I think we need to strengthen our infrastructure. And therefore I think today's talk was excellent idea to have this kind of theme or the scope of the discussion. I think I am not expert in that other than health, but I am sure that Dr. Madan Gopal has elaborated before I joined. So because he is holding a position in the Niti Aayog, and Niti Aayog, obviously he is also looking after the health sector. But probably other than health, I must emphasize that other than health also, we have developed, we have progressed a lot in last 10, 20 years, but definitely we still have huge scope. Our roads, our connectivity has definitely grown up like anything, but it is a huge country and we need to have lot more to do. Another example in health sector was that during the COVID time in ICU, our doctors and nurses were also a little bit concerned. They were not able to frequently visit the patients, and patients used to complain that no doctor is coming, I am calling this and that. And by that time, I am talking about 2020, when the vaccination was not there and not many facilities were there. And sometimes even in the early days, all we know that we were not having even the good quality of PPE. So that time, I asked and I searched Google also that, if there are some robots which can, deliver the medicines or can take temperature or, can read or something like that. And one company from Singapore only, they had some dealer in India, and we inquired from them that, but they also inspected the ICU, and then they said that you need to have the robot accessible doors, means sliding doors, and that is possible only once you close the ICU, and that was not possible because patients are already there. You cannot you need to replace the doors, the conventional doors, with the sliding glass. So that was some of the very minute things sometimes we need to think. And then I think there is a huge scope in this country to the entrepreneurs and those small and middle level the companies, they are coming up. And I'm sure that people like you, those who are through your magazines and other media, through conferences. You are doing a great job, and I think that other people will be elaborating more. So I think with that, thank you very much for giving me opportunity, even though I am not expert, but you invited me. So thank you very much.
Thank you, Professor Singh, for your opening remarks. I would now like to invite Dr. K. Madan Gopal from Niti Aayog. Uh, Dr. Madan Gopal, without mentioning or without discussing digital health, hospital infrastructure, the discussion on hospital infrastructure remains incomplete. Can you please shed light on how Niti Aayog is driving digital health in India? What is the roadmap? How crucial will be the role of digital health in building hospital infrastructure for all in this country?
Thank you, Mirmoy. A very interesting question. But nowadays, you have to come to the fact that medical practice and medical care is very, very different. Just a digital thing would aid the medical practice, but it will not replace the medical practice. That we should be understanding. Another caveat which we have to think is we have to build practice into technology, not the technology driven practice. Because technologies are there to aid and uh, ease the workload. It can shift the task, but it can't replace the task. That we have to understand that. So, having said this, I will just cite the example how we have been trying to build the technology. So, the journey of this electronic health records, the telemedicine, they started way back in early 2000. That means 2004-5, the telemedicine started with the district hospitals and other places connected with medical colleges. That experiment has happened. That means the thought process was there. If you look at the ministry website, so we are having a website for each and every activity, every program which we are handling. So there was a thought that why can't we integrate all these platforms so that with a common identifier we can extract information pertaining to a particular patient or particular person. So I'm talking about the early decade. That means 2008-9 to 2013. So then in around in the early 2011-12, I am not exactly remembering the date. We started with an integrated approach with the help of WHO and others. So they tried to build an integrated health information platform. If you talk about a person, the person gets treatment for malaria, the person gets treatment for diarrhea, the person gets treatment for TB, but all the programs collect information differently. So there is no common. Suppose I want to say that how many people who were vaccinated had COVID and not COVID. Because we don't have a mechanism to capture that. Whether if I'm getting BCG, then you have to do another study. To ease that thing, the integrated health information platform is there, and most of the programs will be riding on that platform. Simultaneously, when the mechanism started in 2011-13, where we have a national resource center for this e-health, and we had national collaborating centers also. We started like that. Then subsequently, when the PMJ was launched, the immediate question was that how to launch it, because the RSV previous RSV version of this health insurance scheme was having some technical problems in the form of transaction software and other things. When we were evolving the transaction software, then it thought that we should be having a stack in which all the other program data rights, because the person 50 million people would be coming and utilizing the scheme, we should be having their information as well. So a stack concept of national health stack came, and after consultations, then we evolved another, that is national digital blueprint, that evolved as a national digital blueprint, and on the architecture which has been provided in the digital health print, that resulted in the formulation of a national digital health mission. So in this way, the journey started. The journey is very simple. That means each and every individual would be having an electronic record. Doctor would be having an ID. The institution would be having an ID, and both the programs in the Ayushman Bharat, we are having two pillars. One is the PMJ, other is the Health and Wellness Center. One talks about the population. One talks about the hospital-based care. Once this kind of electronic health records and other things are generated, then you see that how it would be easy for giving the treatment across the country. That's one other thing. Second thing, the other thing, before the COVID times, doing a teleconsultation, WhatsApp consultations, and other consultations were illegal, and the honorable courts have taken a cognizance of that, and they have passed many orders uh, against doctors who are prescribing. During the COVID times, when we were grappling with the issue of providing care to the non-COVID people, then that was an opportunity, and we have utilized that opportunity, and the guidelines for telemedicine were released during that time by the Medical Council of India. So we have facilitated that, and as a result, a new thing has opened up. Now you are seeing that many telemedicine platforms are there. But in future, what can happen? Then we have to see that how the aggregation of this telemedicine platform happens. Another thing which in the opening remarks Karthik has mentioned, that the quality of care is quality of, it's not just only having that so many institutions, or it's more or less we are infrastructure related quality. In the telemedicine also we are having infrastructure related things only to say it on a broader perspective. We have to see that what is the quality of telemedicine consultation which we are offering. It's just saying, asking the question, and who is providing? Who is providing training to this counselors who are managing this telemedicine counseling? Whether this telemedicine is resulting into referral, if a referral is happening, whether the service provider, the telemedicine provider, is arranging for a bed in the hospital, or you're just leaving as such that you have to go and fend for yourself. Unless this circle is completed, whatever technology you would be using, so we have to see that you have to use it with caution. Unless you complete this loop. In COVID times, you have seen that they were charging 2,000 rupees or 6,000 rupees package for providing home-based consultation. The moment the saturation dipped down, and the patient was to fend for himself for a hospital bed and the oxygen cylinder. If that kind of services without proper follow-up and without attachment to an institution that I am providing teleconsultation in case of need, whether the person will be treated in that hospital or not, that assurance is not there currently. We have to see that how we address that issue and take the things forward. It's not a magic bullet that digital health is there, it will solve all the problems. No, you will be requiring infrastructure, you will be requiring HR, manpower. If more consultations, then you require people to understand. If I am sitting in Delhi and giving some suggestion to the lower top, if the lower person is not trained to execute that commands, then what is the use of having this kind of, it's only for the sake of saying that I am doing this thing, I am having a EICU. I'm just citing an example of EICU. What big hospital chain in the small town of Chhattisgarh, they were consulting. The patient asked that, sir, if you are not able to provide treatment, then I'm not interested in taking treatment. How to address that kind of concerns in the EICU setup? Though technologically it sounds very good, but the patient is not interested, saying that I want that the person treating person should be there in my hospital. And how to address that issue? These are many issues which will be coming up, and slowly as the things will evolve, we will be trying to address all these issues as well. Over to you, please. Thank you very much.
Thank you, Dr. Madan Gopal. I would now like to bring Professor Singh. Professor Singh, can you hear me? The primary objective of premier institutes like AIMS have been, research and training. How do you see the role of premier institutes like AIMS, in the future of India's healthcare or hospital infrastructure? How do you want to reflect your leadership in this landscape? If you can shed some light on that.
Yeah, thank you. But before that, I would like to take it forward what Dr. Gopal very nicely and very honestly he said that no technology is magic bullet, and we need to evolve with the time. And human interface, probably it is very difficult to say that we will be replacing the human touch, particularly in health. And therefore, Dr. Madan Gopal, and we have on the digital platform we have discussed earlier also, and I appreciate that his very honest opinion. So that is definitely there, because he gave some of the examples. Another example is that until otherwise networking is there, and even if networking is there, you are in one hospital and I am teleconsulting. I say that you go to this hospital. This is available in the map, which digital health says, but you are not ready to accept. What will we do? So, and then also the more and more doctors, nurses. The aim of the digital health mission is that through this, every healthcare worker and the organization, they will be networked, but it is volunteer. So I was seeing on the day of its inauguration by Honorable Prime Minister, there were only about less than 4,000 doctors, those who registered, but I'm not sure that how many are now registered. So this has many advantages, but definitely this will come with time, and acceptability will come again with the experience, if by word of mouth, and from seeing the advantages by others. So it will take time, but definitely it is a good move, and definitely we can hope that it is going to not only in health sector, coming to research and development also. It might help through, though not directly but indirectly, because ultimately the clinical research is also patient driven. So if we can have many research questions answered through this agency also, because right now, as he very rightly said, that we don't have any idea that you have to survey for the how many are vaccinated with the COVID, BCG, or like rabies, how many cases and other things. So every consultant or every project is taken up by government or by the PI, individual PI, in an individual project mode. There is no comprehensive nature that so that is on the click away that you can have the data of the how many are this patient and how many are infected with another disease. Similarly, this also has wonderful opportunity for the researchers and managers in the government, those who are like Niti Aayog and others, that the pattern of the drug uses, that is also a research question. As of now, the government of India, through National TB Elimination Program, earlier it was known as TB Control Program, they had two softwares, and the aim was that they will be able to track the anti-TB drugs in which state and which district they are being used. But that is still so I think complicated, and not much has come out of that. And I think if this can be integrated, which is already aim of this mission, but that can come out, and then that can help the country as such, that even the Prime Minister in his office, he can find out that say for example, third generation antibiotics, what is the pattern where these are being used or misused. Like another day on one file, I was saying that colistin in our hospital, my own hospital, I am saying, I was signing one file, colistin is being used so rampantly. This is a reserve drug. This should not be used. So that kind of things. So this can track the where the drug is being manufactured, how it is being transported, which pharmacy or which city it is going maximum, and who are the doctors or hospitals who are using maximum and why. So if there is any pattern, say for example, there is a epidemic, or there is some more cases or overuse, or doctors are not using properly. So that kind of things are there, and definitely the infrastructure as far as research and development is concerned. In research, we are too much dependent on Western world. I can say only Bangalore and Hyderabad, these are the two cities. Bangalore was the first where some of the chemical reagents and some molecular reagents, they started manufacturing. But if you see the entire country, the need, demand, and supply, be 90% reagents and chemicals are still being imported from the Western world. So I think there is a research also, because and these are very costly, and that is the reason probably that many of the research projects either they are delayed or they are not able to meet the expectations of the funding agency or the public at large. So these things definitely we need to develop our own, chemical factory, reagent factory, molecular technologies. So we are starting, but a lot more has to be done. And therefore, probably I can say with proud that, as far as faculty development is concerned, AIMS Bhopal has established unique department, that is a translational medicine center. And in this, the aim of this creating this department is that this department will have a bridge between the clinical departments and basic department. So this will be able to develop the the devices and the equipments or kits, or develop vaccines, and then partner with the commercial organizations, and then the things can go to the masses. The idea to develop this department is that, probably a hospital setting knows better that what is right now required. We have many research laboratories, but they have their focus. Say, for example, they want to do calcium channels. All right, very good. Basic science is very good. But how much, what is the market, how much need it is, and whether it will be useful or not, then clinical evaluation, then integration, then inputs of the clinicians. So therefore, this department and the faculty of this department will have access to trial of these products, new products if we come up, as well as we will be able to find out that what is the need of the patients or the country. So that will also be day-to-day basis, because all faculty from clinical treating departments as well as from this department, they will have interaction, and they will so need and supply both will be met. And therefore, I think the country is progressing, and this kind of avenues we are opening up, and in future this kind of infrastructure and the accessories and the reagents, chemicals, another these are the some of the I think needs. But let me give you some of the examples that even the dry ice, what we have, it is a CO2, dried carbon dioxide. How many cities, how many courier services? We have only two. Now, very, very small things. Sometimes, as a researcher, also we realize that we we don't have. So only Delhi. You have to ask either Delhi or Bombay. No other city has these CO2, because probably the company said that they don't have consumption. But obviously these things, they will the demand is there, but supply is not there. So whether if the supply will increase, you people are business people, so you will know, the marketing people. I am not a marketeer, but definitely whether chicken and egg situation, the supply should increase first or demand should be met first. So these are the things. That is the reason that probably many vendors, whenever we ask that why it is not in Bhopal or like cities, like small cities, so grade 2 cities, the answer is that we don't have market here. But that is my question, that whether we should develop the market, or you should look for the wait for the market to come for you. So these are some of the thoughts. I think they are important, and we have to, in clinical science and research, both are integrated, because we are hospital setting. Being a doctor, I can't talk much about the basic sciences, but applied science as of now today, because basic science has their own aim is different, because they will be in the small laboratory. But my focus is that when we talk of the healthcare, I think the applied research is more important, and then we need to look forward that how the clinical needs through research, they can be met. Thank you.
Thank you, Professor Sharman Singh, for joining the second edition of Elets Hospital Infrastructure Summit. And we also thank Dr. K. Madan Gopal, Senior Consultant for Health at Niti Aayog, for joining this second edition of Elets Hospital
Thank you.
Infrastructure Summit. As a token of our appreciation, we would like to present Certificate of Participation to you.
Thank you. Thank you.
Thank you, Dr. K. Madan Gopal, for joining the Hospital Infrastructure Summit by Elets. Thank you, Professor Sharman Singh, for joining this inaugural session at the Elets Hospital Infrastructure Summit.
Thank you.
Thank you.
Very much.
Thank you, and stay safe. Viewers, please join us at the next session of this